as we know, most stimulant medications are approved by the FDA in the United States for up to ages 55 to 65. The number of people saying they hit age 65 and their doctors refuse to prescribe a stimulant, whether it's new or a re-prescription. Is this level of caution appropriate, a hard cap at 65 years of age?
So my simple answer is almost any hard cap is denying the individuality of certain humans. I mean, humans vary. So cardiologist groups, interestingly, have not weighed in strongly on this. And at least some groups have actually said, what makes sense if you're concerned, if there's other cardiac issues going on. And for all of us, as we age, we are more likely to run into developed cardiac issues. It's to get an evaluation. I mean, this may be a point where you didn't have an EKG for 20 years on it, but if you're hitting 55 or 65 or some other, again, somewhat arbitrary cutoff. I have patients who have been in their 80s, one even in their 90s, who continue their medications safely and with great benefit, strong stimulants, so Adderall, amphetamine-based products, or Vyvanse. I've had some who needed to decrease their dosing because they needed less to get a beneficial effect. But I have not seen, again, my sample size isn't going to be vast, but none of them have run into problems of cardiac complications. So I can say there are at least some individuals who do well on stimulants into later years and are not having cardiac adverse effects. Another issue related into this regarding anyone on stimulants who's having increases in blood pressure. There are certainly some people who are sitting on the borderline between hypertensive and not, and who are pushed into that by these medications. And often in consultation with the cardiologist, the answer is we can use a blood pressure lowering medication. Again, guanfacine can be a useful tool there, or something else. So antihypertensive, so blood pressure lowering medications, can be used safely with stimulants. And sometimes the cardiologist's recommendation is don't stop the stimulant, but to just go up on the antihypertensive because the person's getting benefit from both medications. So.
Okay, that's very helpful. There's a number of people here who say they've been told that due to a history of hypertension, stimulants are simply out of the picture for them.
Yeah, I can say I certainly worked with people whose primary care doctor or others were said that they needed to stop. So the other thing I've had is people where it was a question whether it was having an impact or not. And again, most of the effects, both physiologically and the central nervous system on the brain from the stimulants, are immediate direct effects. So if your blood pressure 2 hours after taking your Vyvanse compared to what it was before, and you do it a few days on and you do it a few days without, and you're not seeing that the Vyvanse is having a direct role, then I would say clinically that is demonstrating that this is not a part of what's contributing to this individual's hypertension, and therefore it's safe to continue to take. But I certainly have seen what the people writing in are saying is it's not uncommon for doctors to be overly cautious. I mean, some of it I think is genuine concern about patient welfare. I think some of it is if they're seen as prescribing outside of guidelines, then if something bad happens, they're going to get in trouble. But I think we should be first and foremost focused on patient care, not on, as I will say bluntly, cover your ass medicine.
You talked in your presentation about the fact that ADHD medication use is not linked to brain damage. But a number of people are wondering if there is any evidence indicating that long-term stimulant use carries any other health risks that they should be aware of.
So again, separate from the immediate cardiac death, again, there is some sign of, I'd say, more serious, but again, it's a small risk. 96% of people at 15 years weren't showing any sign, but that meant 2% above what the background placebo rate of 2% were having troubles. Yet the thing when I'm talking with individual patients, it's really important to emphasize is that ADHD itself kills people. And I say it that bluntly because the data is pretty darn clear. That on average, if you've had ADHD since childhood, you're likely to lose 7, 8, 9 years of life. That doesn't mean some people don't live a long life and some die tragically short, but on average, it's a substantial contributor. And the two big causes seem to be suicide and accidents. So all sorts of car crashes, clumsy events. And if we can prevent those for most people's bodies and brains, it seems that the cost benefit analysis is strongly in favor of the stimulants. Is it possible? So there's one concerning study suggesting rates of Parkinsonism might be higher. What's difficult there is Parkinson involves degradation and destruction of dopamine neurons in the substantia nigra, but we know dopamine neurons are also going to be affected in many people with ADHD. So it's really, the study was well done. It sounds somewhat concerning. Again, the overall rate was the vast majority of people are not developing Parkinson's, but even if it's a relative increase in risk, that would be nice to know. But it's hard to sort out confounding variables and sort out, is it really the ADHD which increase the risk, or maybe the more severe forms of ADHD that increase the risk rather than the medication used to treat it?
Okay. Yeah, I will mention there's a link on the Attitude homepage to a write-up about a new study that just came out, I think last week, on about 150,000 people with ADHD, showing, as you said, stimulant medication use significantly lowered the risk of suicidality, criminal behaviors, vehicular accidents, and substance misuse. And it just is another in a long line of studies showing the same. I will move on to our next question that I see a lot of, and that is there any evidence to suggest that stimulant medication loses its efficacy with time? So in other words, should patients consider medication vacations, or perhaps taking medication less than 7 days a week or at a lower than optimal dosage? There's a lot of advice being given about these strategies.
Yeah, there's a lot of advice, and there has been since I started in this field in the mid-90s, and extremely little evidence whatsoever. So one of the things I did 3-4 years ago, and this is just within my own practice, in terms of sorting out how common is tolerance. So I looked at the first, I went in alphabetical order and found the first 100 patients I was working with who had been on a stable dose for a year. So we're not discussing were they titrating up initially or sorting out a dose, and then just looked a year later, are they still on the same dose, or did they go up or down? And again, I'm not saying my population is representative of all people with ADHD, but I think and 80% of the individuals were on the exact same dose a year later. So one, that's saying, at least in my practice, most people aren't needing to go up. And of the little less than 20% who changed a dose, it was actually equal amounts of people going up or down on the dose. So that would suggest there's either equal likelihood in small of both sensitization or tolerance, or the other thing it emphasizes is that we're always talking about a brain interacting with its environment. So not just the medications going into it, but also changes in job, changes in partner, changes in world environment. So some of that pseudo study I did or informal study was during COVID. So there were stressors there. But to me, it was fairly reassuring and refuting. And again, it tends to be the addiction specialists who they are only seeing the narrow percentage of people who run into problems with these drugs. So I don't see tolerance as actually a particularly common problem. Most of the patients I've worked with, and some I've worked with for 25 years, are usually continue to get benefits from the same dose unless life situations change dramatically.
Okay, that's very helpful. We've seen over the years, as I'm sure you have, that the stimulant shortage has impacted quite a few patients. About 7% of the people here said that was the reason why they stopped taking their medication. But a lot of people have had to, for various reasons, switch to generics, the generic version of their preferred medication. And they said, it doesn't work the same. Is that possible? Is that true? What might be going on that the generic version would not have the same effect or might carry different side effects than the name brand?
So I do have colleagues who think that the difference is, that the FDA requires that it's the same substance and that its release is roughly comparable. But roughly comparable means there's a 15 to 20% slop in terms of how quickly it reaches the peak level and the total amount absorbable or area under the curve. So there is some variability that's allowed by the FDA. And what's really, so it's interesting. Again, I have colleagues who think this is all just a psychological problem, that it's kind of like when you're doing a wine tasting and telling people this is a $200 bottle of wine versus a $20 bottle of wine. You get many more people saying, oh, the 200 one's really great. It's working. I like the flavor. And often in these studies, they're actually the same bottle of wine. So I'm not ruling out that there are some people in some cases where it is a psychological effect, but I believe that there are physiological reasons that there could be, some people will detect differences. And it's interesting, in my clinical practice, the two groups of medications are the stimulants and the benzodiazepines or Valium-like drugs, where people fairly commonly notice brand name generic differences. And not that it doesn't happen, but it's much less common with slow indirect drugs like antidepressants, like Prozac. And I think, again, part of the reason, and we know with stimulants, strong stimulants, part of the response isn't just the concentration of dopamine or norepinephrine at that second at the synaptic junction. It's how quickly that dosage is changing from the previous minutes. And if you have a drug that goes in a little slower or faster, you aren't just getting a subjective difference that this feels different. That can certainly be there and add into the sensation, but you are actually probably getting different physiologic output from the system because of that. So again, the first part, the subjective part, I think that does have a role. So I've had lots of people who are on, Adderall immediate release when we were titrating initially to see what they were, whether it would work or whether they'd respond, and then they'd switch over to Adderall XR, and this is even within brand name. And they'd say, the immediate release work, but this stuff doesn't do anything for me. And I'd say, it's the exact same chemical, it's the same company. How can it not? And again, daily dose is one part of the phenomenon, but how quickly that dose, how large a dose at that instant is at the receptors, and how that difference from what happened the second before is a part of the physiologic action of stimulants.
Okay.
And I'll also say that for Concerta, the FDA themselves acknowledged that several of the generic versions were not biologically equivalent, even though they were chemically equivalent.
So if this has been your experience, it is, in fact, not in your head, likely. Also, there may not be a great solution on the horizon, but it's good to know.
So one thing many doctors aren't willing to do it, and sometimes it doesn't work, is that you can petition your insurer to say, the Sandoz brand and the Teva brand haven't worked for me. I need Abbott brand of certain drug. And the challenge there is it may be harder for them to get hold of it. Sometimes the pharmacy isn't particularly willing to cooperate, even though technically they are allowed to and can, and the doctor can write orders that way. But oftentimes doctors aren't willing, and there can be pushback from the pharmacy, and or more delays with each filling. But that's an option for people who have noted clear and consistent differences. And at least in the US, on the label of your pill bottle for the generic, and it's usually in tiny, tiny print somewhere, it will specify which generic maker you have each month. So.
Okay. We are almost out of time, but I did want to refer people who had asked questions about supplements and those that have science behind them. I believe, Dr. Kruse, that you have done some videos on a few of these supplements on your YouTube channel. So I was going to refer folks over there to learn more about non-medication alternatives. Does that sound like a good next step for those people?
So I think the link is on the slides, but that's Dr. John Kruse, DrJohnKruse at YouTube. It's a free channel. And I do have talks on lion's mane and fish oil and magnesium and a host of other substances, ketamine, some of which I think we have no evidence for. And ketamine, there's at least the risk for harm, something like lion's mane, probably low risk for harm, but again, not a lot of data yet. But yeah, I do have more, and more videos will be coming because there's clearly interest in alternatives to prescription drugs.
Indeed, there is. So as you said, we could have done a whole series on all of the topics you touched on today. So I appreciate that as a next step for folks who want to dig deeper in medication and medication alternatives. So we are out of time, but Dr. Kruse, thank you so much for joining us today, all the way from Hawaii, getting up very early to contribute your voice and your breadth of experience to our ADHD community.